Hi, I'm Ned Kalange. I'm the president and CEO of the Colorado Trust. We believe that all Coloradans should have fair and equal opportunities to live healthy, productive lives regardless of race, ethnicity, income, where we live, or the other differences that affect opportunity. I have to admit to you that I woke up this morning full of hope. It's my hope born of the belief that we're a people who are at our best in facing challenges when the challenges are the greatest. It's hope fueled by a heightened sense of urgency for us working in this vitally critical space of health equity. I know there have been tragic events over the past couple of years that have challenged and threatened us. And now with the election, I know there's great uncertainty about the future. While I know that uncertainty brings new challenges and formidable obstacles, I also believe where there's uncertainty, there are opportunities. We must take opportunity to recommit and redouble our efforts to address the inequities in our communities. How we move forward from yesterday depends on how we show up, how we do our work. The Colorado Trust is undaunted, unwavering, adamant about pursuing our work in health equity. And I'm really turning to you, our colleagues and partners, to join us. I'm inspired. I mean, how can you not sit in this room and not be inspired by the people around you? I'm inspired by those in other communities who will watch today's presentation and use it to dialogue in their communities about issues around health equity and race. I believe our strength as a country is rooted in our diversity. I believe that our unity comes from our ability to embrace across difference. Today, we have to accept the responsibility of helping our nation heal, helping our nation come together, and realizing the promise of equity and health for all. Now, I'm proud and I'm humbled to be here with such a strong ally in our work to advance health equity. A short time ago, Dr. Rachel Hardeman co-wrote a piece for the New England Medical Journal that linked police-related shootings to structural racism, which Dr. Hardeman called the common denominator of the violence that is cutting lives short in the United States. This piece provides a remarkable overview of how structural racism impacts health, not just for communities of color, but for our entire society. We'll post a link to the article on our Health Equity Learning Series website in the next day or two, and I hope you'll take the advantage to read it. It gives me hope to know that people like Dr. Hardeman are actively working to address structural racism and other important issues and spreading the health equity message in the medical community and beyond. Before I turn things over to Dr. Hardeman, just a few notes. We'll email you an evaluation survey after today's presentation. Please keep an eye out for it and complete it. We honestly do read every evaluation and use it to plan our work going forward. Materials will be posted on the website after the presentation today, including the slide deck that Dr. Hardeman will use, the article I mentioned, and in another couple of weeks, a complete video of today's event. I also want to acknowledge the 20 grantees for the 2016-2017 Health Equity Learning Series who are listed on the screen. These organizations are hosting community viewings of today's event across Colorado. The viewings will be accompanied by professionally facilitated discussions, and if you'd like to participate or find a viewing event near you, please visit our Health Equity Learning Series webpage, and you'll see links to all of our grantees' websites and their schedules. These will be taking place in the state in the next few weeks. So now I'm pleased to introduce Dr. Rachel Hardeman. She is a health inequities researcher whose work focuses on the provider contribution to equity and quality of healthcare delivery and the ways in which race can impact healthcare. She has focused extensively on prenatal care delivery and persistent disparate birth outcomes for African American women. She's also a leading expert in medical education research, focusing on the experiences of underrepresented minority physician trainees and how physicians can be trained and are trained to provide equitable and bias-free care. She holds her doctorate in health services, research policy and administration, and a master's of public health, both from the University of Minnesota School of Public Health. Please help me in welcoming Dr. Hardeman.
Good morning, everyone, or almost good afternoon. I'm really, really happy to be here and have had a great experience learning more about the Colorado Trust and the work that is happening here in Denver and in Colorado around health inequities. I'm also really excited to have a family member in the audience, my cousin Laura, and a colleague of mine, a former colleague from Minnesota, Megan. I certainly feel like I'm among family, and that was apparent at dinner last night as well with folks from the Trust. I want to start by acknowledging the new kind of political climate that we have found ourselves in. And, as a Black mother, as a Black academic, as a Black woman, and a member of the Black community, I spent yesterday in mourning, as I'm sure many of you have as well. For me, the decisions our country made on Tuesday are not simply about who's going to run the country for the next 4 years, but the fact that I walk among, work among, send my 3-year-old to preschool among people who are willing to offer a racist, a sexist, and a misogynistic person the chance to make decisions about our communities, about my family, about my daughter, and our livelihood. While I wasn't necessarily the hugest supporter of Hillary Clinton, I knew she was our best chance. She was my best chance at being able to look my daughter in the eye and tell her that the work that I do when I get up in the morning and the work that I do when she goes to bed at night and I open my laptop and I keep writing and I keep researching, that it matters. And like Ned said, he's feeling more hopeful today. I'm still getting there. I'm working on it. And I think putting this presentation together and talking to you all today is helping me towards that point, and I hope it will help you all as well. But I do have to say that prior to November 8th, I could see and envision a world where one day my daughter could be president, as she so confidently declared that she would be when we went to vote last week. She told me she was going to be both president and Princess Anna. She's obsessed with Frozen right now. And so I say this to say that usually when I give talks like this around racism and health inequities, I do so with a lot of hope and a lot of belief in the greater good and the fact that we can make change and that we're slowly making our way towards that. And so I just want to put it out there that I don't have as much of that today, and I hope you all will bear with me. And I think I'll get there again. I think we all will get there again. And it's a long process, and it's an important one, and I think this conversation is an important piece of that. Now more than ever, we have so much work to do, and I'm so happy that you all are here to continue the conversation and to continue that work. So I want to start, So I want to start by sharing with you an article that was published in the New York Times, actually before November 8th, and it was written by African-American activist and actor Harry Belafonte. And he started out by saying, "What old men know is that everything can change." And it's a really, really kind of disturbing, he had some very important foresight around kind of what might happen and what could possibly happen and what has now happened and what we're faced with. But he also uses Langston Hughes' poem, Let America Be America Again, to kind of describe our history and where we've been and where we are now and the potential pitfalls of where we can end up. And so I just want to share a little bit of what he wrote, kind of to set the stage for the conversation that I hope that we can have today. So he says, It was an America where the life of a Black person didn't count for much, where women were still second-class citizens, where Jews and other ethnic whites were looked on with suspicion, and immigrants were kept out almost completely unless they came from certain approved countries in Northern Europe, where gay people dared not speak the name of their love, and were passing as white, as a WASP, as a heterosexual, as something, anything else that fit in with what America was supposed to be, was commonplace, with all of the self-abasement and the shame that it entailed. It was an America still ruled at its base by violence, where lynchings, and especially the threat of lynchings, were used to keep minorities away from the ballot box and in their place, where companies amassed arsenals of weapons for goons to use against their own employees and recruited the police and National Guardsmen to help them. These private corporate armies proved insufficient, where destitute veterans of World War I were driven from the streets of Washington with tear gas and bayonets after they went to our nation's capital to ask for the money they were owed. Much of that was how America had always been, and we changed it. Many of us, through some of the proudest struggles of our history. It wasn't easy, and sometimes it wasn't pretty, but we did it together. We won voting rights for all. We ended Jim Crow, and we pushed open the golden door again to welcome immigrants. We achieved full rights for women and fought to let people of all genders and sexual orientations stand in the light. And if we have not yet created the America that Langston Hughes swore will be, the land that never has been yet, if there is still much to be done, at least we have advanced our standards of humanity, hope, and decency to places where many people never thought we could reach. He goes on to say, but what old men know too is that all that is gained can be lost. This phrase hasn't stopped resonating in my head over the past couple of days. And I think that in order to minimize our losses in the world of health inequities and in the world writ large, there's a lot we need to understand and a lot of work we need to do. And so with that, I would like to start by talking about a subject that I don't often bring into my discussions around racism in health, but I think given what's occurred over the past couple days, it's an important place to start. And that's with white supremacy. White supremacy is what has changed our political climate overnight, and we need to understand what it is, what it looks like, and if we're going to have any more forward traction in eliminating health inequities and health disparities, we need to be able to define it, we need to be able to say the words, and we need to be able to accept it as part of what has created the inequities in our society. So white supremacy is a historically based, institutionally perpetuated system of exploitation and oppression of continents, nations, and peoples of color by white peoples and nations of the European continent for the purpose of maintaining and defending a system of wealth, power, and privilege. It also can be described as a political ideology that perpetuates and maintains the social, political, historical, and/or industrial domination by white people, as evidenced by the historical and contemporary socio-political structures such as the Atlantic slave trade, Jim Crow laws, and the US and apartheid in South Africa. White supremacy is at the root of structural racism and the persistent health inequities, but we don't often talk about that piece of it when we talk about health inequities and health disparities. And I really think that we need to move our conversation in that way to be able to really dismantle the systems that have created these persistent inequities that we're seeing in our communities. White supremacy is what has allowed Black men to be shot and killed by police officers with little or no recourse. And it's my hope that those of us that are doing this important work can begin to use that phrase and use that language and get comfortable with it. As hard as that is, we have to get comfortable with the language that we're using and really say what we mean and mean what we say. Issues of race and white supremacy and structural racism have been at the forefront of our news and media, and certainly during this election cycle, but they were particularly highlighted in the media going back to when George Zimmerman shot and killed Trayvon Martin. We've seen headlines discussing America's race problem, and we've really been forced to grapple with, or at least have been unable to turn away from the fact that race is deeply embedded in our society as Americans. And the Black Lives Matter movement in particular has highlighted the insidious impact of structural racism on the health and well-being of Black communities as well as other marginalized communities. So I know it's a lot. I know it's a lot to process, it's a lot to handle and understand, and it's complex and it's disturbing. I do want to mention that when I talk about structural racism and white supremacy, I'm not talking about individual perpetrators. I'm not talking about individual racists. That's not what this discussion is about. It's about the systems. It's about the structures that are in place and the ideologies that have allocated privilege based on race for many, many years. And the fact that if we don't understand and recognize it, then we're playing a role in perpetuating it. So now I want to take a step back and talk about race as a social construct. I think it's an important piece of understanding why health inequities exist and understanding what we can do to eliminate them. So the idea of race emerged as a justification for New World slavery in the 17th century and legitimized a social hierarchy that privileged whites. At first, enslaved Africans received treatment only marginally different from that was afforded other members of lower ranks. In the second half of the 17th century, slave laws were passed to secure the labor force for plantations and to prevent coalitions between Black slaves and white indentured servants. Status differentials between Blacks and whites solidified, and indentured servants from a variety of European nations began to see themselves as a white race for the first time. Racial beliefs have always been tied to social ideas and policy. After all, if differences between groups are natural, then nothing can or should be done to correct for unequal outcomes. The scientific literature in the late 19th and 20th centuries explicitly championed this view, and many prominent scientists devoted countless hours to documenting racial differences and promoting man's natural hierarchy. Although today many of those ideas are outmoded, it's still popular to believe in innate racial traits rather than look elsewhere to explain group differences. We all know the myths and the stereotypes that natural black athletic superiority, musical ability among Asians, but we really need to continue to ask ourselves, are these really true on a biological level? And if not, why do we believe them? You know, there was an example a study that came out in 2015 from the University of Virginia that found that 50%, so half of medical students and residents at the school endorsed beliefs around race being biological. So these students would answer questions such as Black people's blood coagulates more quickly, or Black people have a higher tolerance to pain. And one of the other findings from this work was that people who were more likely to endorse those types of beliefs were also more likely to hold implicit racial bias. So we have a lot of work to do to debunk a lot of the myths and understand that race is a social construct. And from this, we've created what we call today racism. So a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race. So structural racism then is a confluence of institutions, culture, history, ideology, and codified practices that generate and perpetuate inequity among racial groups. Structural racism is often normative. It's sometimes legalized, and it often manifests as inherited disadvantage, and a lot of times it's very insidious. We aren't always acutely aware that it's even operating. So I think it's always important to have the discussion about health inequities and health disparities within this construct of structural racism by distinguishing the difference between inequities and disparities. I think for a long time in the field of public health, we've talked about health disparities. And we use the two, disparities and inequities, interchangeably. And it's important that we, again, are thoughtful about the language we use. So a health inequity is a difference in health that's a result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. So it's those avoidable and unjust differences that are linked to systems and structures. Disparities, on the other hand, are the differences in incidence, prevalence, mortality, and burden of disease, and other adverse health conditions that exist among specific population groups in the US. And that's the definition that the National Institute of Health uses. So for years, researchers have asked, is there a difference in health status rates between population groups based on a variety of different health outcomes, failing to link that to the systems and structures that have created those differences. So again, the language we use is important. You know, as I said, we've been stuck on disparities for decades without cultivating our understanding of inequities. Inequities cause disparities. Structural racism causes inequities. While disparities are very real, those differences are very real and undeniable, but they're also a very real distraction in my mind from the issue at hand, which is structural racism. So now I'd like to share with you a few examples of the link between structural racism and health inequities, just so we kind of understand how this is operating and the different ways that it can create those inequities in health. I'm sure you all have heard a ton about the Flint, Michigan water crisis, and I think it's an important, it's a casebook study of how structural racism has impacted health. Flint is a city that's almost 60% African American. It's incredibly poor, and since 2014, they've been drinking and bathing in water that contains enough lead to meet the Environmental Protection Agency's definition of toxic waste. And the most recent report on Flint found that, or stated, Flint residents who are majority Black or African American and among the most impoverished of any metropolitan area in the United States did not enjoy the same degree of protection from environmental and health hazards as they provided to other communities. And this is a perfect example of where there's no single person to shoulder the blame for the situation. But thanks to widespread mismanagement of a largely Black and brown community, they now face the disproportionate effects of systemic neglect. And to many, Flint's water crisis fits into a historical trend of environmental racism in the US, which for decades has allowed polluters to prey on communities of color and low-income communities, and in part due to weak environmental regulations. Food accessibility is another important example that we need to consider. I'm sure many of you are doing work around, what I think the phrase now is food deserts. So decisions made on a purely economic grounds can produce racial disparities. So when grocery store chains decide not to locate a store in a poorer neighborhood, so when's the last time you saw Whole Foods building a store in a low-income or a Black or other marginalized community? This contributes to neighborhood and food environments that have very little access to healthy and fresh foods, or the foods they do have access to are very expensive. And there's a strong link between that and higher risks of obesity, cardiovascular disease, and diabetes. We also know that there's links between residential segregation and the seemingly neutral policies of financing public schools primarily through local property, private property taxes. So this is linked to poor health outcomes in many ways. There's studies that have shown a link between cardiovascular health and just the idea that certain communities are building wealth and accumulating wealth in ways that a lot of other low-income or Black communities are not able to do. And that's linked directly to housing policies and redlining as well, and the use of race and ethnicity to determine mortgage eligibility in communities. There's been studies that have looked at, for instance, elevated blood lead levels as a result of a higher likelihood of living in older housing that's contaminated with lead-based paint. And African American communities are disproportionately impacted in that way. So now I'd like to share a few examples from the world that I work in, which is prenatal care and birth outcomes. So we know that birth outcomes, the inequities in birth outcomes are persistent. We have not made much headway in closing that gap. Over the years, we've seen an improvement overall, if you look at the general population, in birth outcomes, but when you start to look at things by race and by socioeconomic status, those numbers haven't moved. Minnesota is a perfect example of the fact that we're consistently ranked as one of the healthiest states in the nation, And we have some of the best birth outcomes in the nation, but when you start to look underneath the surface, African American and American Indian babies in particular are twice as likely to die in the first year of life in comparison to white babies. And the March of Dimes actually just produced a report around preterm birth and graded all of the states. And there's a lot of states who got an A or a B when it came to birth outcomes overall, generally speaking, within their populations. And then those grades fell to a C or a D when you started looking at the differences by race and by socioeconomic status. So we know there's persistent inequities and disparities in birth outcomes, so low birth weight, babies that are less than 5 or 5.5 pounds at birth, preterm birth, so babies that are born before 37 weeks gestation, infant mortality, and maternal mortality as well. So New York in particular has some of the highest disparity, or the worst disparities in maternal mortality in the US. So some of the work that's been done around this, so I should back up for a second to say that there's a lot of work that's shown that everyday discrimination, so women and families walking through life and experiencing kind of the interpersonal encounters of discrimination, that can impact birth outcomes, because we know that stress is bad, bad during pregnancy and all of the kind of physiological stuff that comes with that. But there's less that's looked at actually how structural racism and systems have impacted birth outcomes. And so that's where I'm spending a lot of the time with my work right now. But a recent study did find that the joint effects of structural racism and income inequality on small for gestational age birth is associated with, so structural racism indicators are associated with higher odds of small for gestational age birth. And what they looked at were state level indicators like employment, incarceration, education levels, so having a bachelor's degree or not, and then use state level coefficients to kind of assess income inequality as well. And the second study I think is really fascinating. It was published actually in 2013 by a social epidemiologist, Nancy Krieger at Harvard, and she looked at Jim Crow laws. So actually looking at legal discrimination, a perfect example, right, of structural racism, and looked at the association with infant mortality rates and found that there was a beneficial effect at the end of Jim Crow laws on the reduction of premature mortality for Black infants. So while there's little that's looked at structural racism in birth outcomes, there's even less that's actually kind of measured or figured out interventions or thought about ways to disrupt this pathway between structural racism and adverse birth outcomes. One study that was recently published, actually a couple of months ago, I think is really, really important work that needs to be explored further. And it was published in the American Journal of Public Health, if anyone's interested in taking a look. But what they found was that the effect that if all states in 2014 had increased their minimum wage by $1, so just $1 increase, there would have likely been almost 3,000 fewer low birth weight births and 518 fewer post-neonatal deaths for the year. And I think that's a great example of the ways that policy can impact health. And we don't always see the direct, kind of the direct impact there, but more work in that area, I think, will start to help that unfold a little more. I'm also really excited to share an intervention that I'm working on that's recently been funded by the Robert Wood Johnson Foundation. So we are partnering, we meaning the University of Minnesota, are partnering with Roots Birth Center. It's a community birth center in North Minneapolis. North Minneapolis is a community in Minnesota that has some of the worst, well, the worst inequities in birth outcomes in our state. It has a very high population of African American population and is also low income. And Roots Birth Center is one of 5 Black-owned birth centers in the US, one of 5, and the only one in Minnesota. And the midwife there, her name is Rebecca Polston, and she is providing what she calls culturally centered or culturally focused care. And they've been open for a year, and she's seeing amazing outcomes. She's seeing actually she hasn't had any preterm births. She hasn't had any low birth weight babies. But she hasn't had a mechanism yet to be able to document the work that she's doing. And so that's what we're really excited to be able to do. And in some of the conversations that we've had with her and with her staff, she talks about how they are working to disrupt that pathway between structural racism and birth outcomes, how they're having conversations with the families, how they talk about the fact that it's painful for a Black woman to know that she is bringing a black boy into this world, given that Jamar Clark was shot and killed less than a mile from where the birth center sits. And so those are the types of interventions that I think are really important to consider as we're doing this work, and really important to be able to have those conversations around how racism is impacting the day-to-day lives of the people that we're helping and working with. So, okay. Before I shift to talking about what we can do and what our role is in dismantling these systems, I wanted to bring up one more thing that I think is important for us to think about and to talk about a little bit, and that's intersectionality, which is a term that many of you have probably heard quite a bit throughout the election season. And it's a theoretical notion that originated by Kimberly Crenshaw in the early 90s, I believe, and was revisited recently in her work. She actually wrote an essay that was published in the Washington Post entitled Why Intersectionality Can't Wait. And in that essay, she makes the case for using intersectionality as a framework for analyzing racial, sexual, and economic justice, the very issues that were at the forefront of the presidential election this year. And she also states that intersectionality was a lived reality before it became a term. So in my mind, it's this analytic sensibility. It's a way of thinking about identity and its relationship to power. So when I do work on prenatal care and birth outcomes, I'm thinking about the intersections of race and the intersections of gendered, and what we sometimes refer to as gendered racism. It allows advocates a way to frame their circumstances and to fight for visibility and inclusion. And I think it's really important to think about the fact that, so today I'm talking about structural racism and really focus my work on the Black community, but there's so many intersections there that we need to consider. So whether you're living in a rural area, and what does that mean for what your experience is as an African American person, or girls of color in the fight against the school-to-prison pipeline, women within the immigration movement, trans women within feminist movements, people with disabilities fighting police abuse. So we all face vulnerabilities that reflect these intersections of racism, of sexism, of class oppression, transphobia, ableism, and more. And if we're not thoughtful about those intersections of all these identities and how they are related to power and privilege, we're not doing our job fully. So I want to switch gears before we kind of wrap up and have a discussion to talk a little bit about our collective responsibility for supporting Black lives and dismantling racism. So Ned mentioned the article that we published recently in the New England Journal of Medicine called Structural Racism in Supporting Black Lives, the Role of Health Professionals. And we wrote this, so it was co-authored by actually my husband, who's a family medicine physician, and my colleague, Katie Casamano, who's a health policy researcher. We wrote this in July after Philando Castile was shot and killed by police about 1.5 miles from the University of Minnesota, where we work. And we were all feeling very helpless and feeling very sad, and needed to channel that in some way that could be useful and could facilitate a discussion among our colleagues who seemingly didn't seem to be as affected by it as we were. I was sitting in my office and feeling like I had no one to cry with and no one to talk to about these things. And so this was one way of being able to do that and to start this conversation. And I will also say that I think what we wrote is not brand new information. We stand on the backs of many critical race theory scholars, W.E.B. Du Bois and others, who have been talking about, and also, people in the Black Lives Matter movement who've been talking about this stuff for a very, very long time. And our goal was really to package it for healthcare professionals and so clinicians and researchers in a way that was, they were able to understand it and to really take it to heart and to put it into practice. And so I'm gonna share with you kind of the 5 things that we talk about in this piece. And while I recognize that not everyone in the room is a healthcare professional, I think that it's relevant for all of us, especially now more than ever, as we move through this world and we encounter people who may not have the same belief system and values as us. It's an important way and an important tool to be able to facilitate discussions and hopefully to come to some kind of understanding. See, I'm already becoming more optimistic. So the first thing we say is that we need to learn about, understand, and accept the United States racist roots. And that's why I started by talking about white supremacy and the social construction of race and what that means. If we don't understand that, then we can't understand why the structures and systems are in place that have created health inequities. Structural racism is born of a doctrine of white supremacy that was developed to justify mass oppression involving economic and political exploitation. So that's a direct quote from the article, and we were really excited to see that the New England Journal of Medicine published the phrase white supremacy. I don't think they've ever done that before. And again, I think it's an important part of moving this conversation forward. So, part of that is understanding the history of experimentation on Black communities, understanding segregation of care based on race and that history and why there's mistrust among a lot of Black communities when accessing the healthcare system. Disparate health outcomes and systematic inequalities in terms of wealth, well-being, and quality of life must be seen as extensions of the historical context in which Black lives have been devalued. We also, sorry about that. So we also talk about the fact that we need to understand how racism has shaped our narrative about disparities. And that's why I always try to make the link between structural racism and health inequities and health disparities. We need to understand why disparities exist and not talk about just those differences. We also need to recognize that implicit biases and false beliefs are common. We all have them. But if we can't, and while that's our reality, we have to be able to recognize that. And we have to be able to challenge them within ourselves and also within one another. We also need to define and name racism. So consistent definitions and accurate vocabulary for measuring, for studying, and discussing race and racism and their relationships to health. Particularly as a health services researcher, we put race in models, in our regression models and our analytical models all the time without giving any thought to what it means and without giving any thought to the fact that there's racism that is behind what race means in those findings. And the same happens in clinical medicine as well, when medical students are taught to present a case by saying, so-and-so is a 60-year-old African-American male. So what does that mean? Why is that relevant for how you're presenting the case? So if we acknowledge and name racism in our work, our writing, our research, and interactions, we can advance understanding of the distinction between racial categorization and racism and clear the way for efforts to combat the latter. I also would say, as I kind of started out this talk by saying, this requires all of us to name racism, to name structural racism, to name white supremacy, and also ask the question in all of our interactions and all of what we're, even if we're sitting in our workplaces looking at our strategic plan, asking how is racism operating here? Because I think we would be surprised at the answer in a lot of those cases. Recognize racism, not just race. So, Black Americans on average have more poorly controlled diabetes and higher rates of diabetes complications than white Americans. So going back to my example of the link between structural racism and food accessibility, being able to recognize that the reason that poorly controlled and higher prevalence of diabetes may be linked to policies around food accessibility and the decisions of different grocery store chains as to where they're going to open up their businesses. Successful treatment is going to require attention to those structural factors, attention to the social determinants of health, and using anti-racism strategies as part of kind of the broader way that we think about health inequities, particularly around these chronic diseases. And finally, we talk about, we use the phrase center at the margins, which has been used in critical race theory quite a bit. And really what we mean is that we need to shift our viewpoint from a majority group's perspective to that of the marginalized group or groups. And I think on the surface, a lot of us who are committed to this cause are doing that in many ways, but I think we need to do more. So that means diversifying our workforce, making sure that the places, the people we're serving, that they can see people in positions of power that look like them and represent them. Developing community-driven programs and research. That's why I'm so excited about this work with the birth center. That work is driven directly from that birth center and the work that they're doing. It was their idea. These ideas don't need to come from the academy. We've created enough of that knowledge, but we need to be able to trust that the knowledge that communities possess is what the real evidence is. Ensure that under-resourced people and communities gain positions of power. So we need to be able to look around the room and see. I would love to, I'm the only African-American faculty member in my department and one of two in the School of Public Health. I need to see more people that look like me in positions of power in the dean's office and in other roles. We have a lot of work to do in that respect. And then recognize whose narratives receive attention and voice. And that's something we're talking about a lot, at least in academia, and understanding that just because you have a PhD and can write a paper and get it published, that doesn't mean that what you say is the full, is the full narrative and the full truth. We need to really start to consider other narratives and give those narratives voice. And then right now, I think more than ever, given the events of November 8th, we need to really focus on creating fully inclusive, equitable, and safe organizations, groups, and other spaces. We need to work to make our communities and places of work a safe haven where we feel empowered to show up as ourselves, as our true, authentic selves within the work that we're doing. And we need spaces where everyone can rest in the knowledge that their importance, that their dignity, and their value as human beings is not questioned. So I would like to close by just saying that while these US election results, they are what they are, they're terrible, they're devastating, they're frightening on many levels. But Harry Belafonte in his New York Times article also says, we changed it, many of us, through some of the proudest struggles of our history. It wasn't easy and sometimes it wasn't pretty, but we did it together. So I'm reminding myself that fight after fight, from one generation to the next, this work is our work and it will go on. Because we will go on, we have to find ways to collectively create a world in which we can all benefit from good health and well-being. And so while I don't feel like I have the answers right now, and I'm sure many of you are feeling the same way, and our strategies may change moving forward. I don't know. I don't know what I might be talking about in the next 3 months. It might shift considerably given kind of the new climate that we're facing. But I think Harry Belafonte's words remind us that we've done it before, and we will do it again. Thank you.
A little table. So I get the privilege of having the first question.
Great.
I did want to point out that it is a diverse group of folks in the room, and for those who don't know, the New England Journal of Medicine is one of the 2 premier medical journals in the entire country. And for NEMJ to be paying attention to this issue and bringing those words forward, it really has a landmark feel to it. And so I congratulate you. One of the phrases you used in there was, addressing violence against black communities can start with anti-racist practices in clinical care and research. And I wonder if you had any examples of successes in that area where kind of doing something with the intervention that's anti-racist in one of those 2 settings made a big difference.
Yeah, I think I don't have any specific examples because I think we still haven't done that. I think it's what we need to be doing. And I draw a lot in my work from critical race theory and which really focuses on dismantling the power and privilege and the structures that have allocated privilege to certain groups and certain communities. And so, part of the discussions that we have with healthcare professionals and researchers are around just that, is setting that stage, helping people to understand those ideas and that's very real. And then, being able to ask a patient. I have a colleague who is a general internal medicine physician, and she is working to figure out ways to ask her patients how for instance, Philando Castile being shot on July 7th by police in their community is impacting their health and well-being on that day as they walk into the clinic. And so, even practicing kind of a level of empathy that I think is beyond what we've traditionally done within healthcare settings, at least, is really important, and a really important piece of that.
Thanks. Maggie Fraser at the front here actually has a microphone, and if you hold up your hand, and as does Julian at the back, if you hold up your hand, we'll get you the microphone. So while people are forming, oh, there's one there.
Dr. Hardeman, I think I just want to start by saying thank you. I think that you spoke words in ways that aren't often spoken, and it was courageous, especially given the climate of the time. Thank you. My question is, when you think about healthcare organizations, whether they're delivering medical or primary care or behavioral health, what do you think? Would you talk to us about what policies you think are critical to be part of the fabric of organizations in such a way that they support, the kinds of delivery of equitable care that you talk about?
Yeah, so thank you. That's a really great question. Can you all hear me? Oh, there we go. So I sit on the mission effectiveness board for our county hospital in the Twin Cities area, and that serves probably has the largest percentage of patients of color and low-income patients in the state. And one of the things that we discuss a lot and have focused a lot of efforts on is one of the things I mentioned in one of my last slides around diversifying the workforce. So recruiting physicians from marginalized communities has been kind of a value and a strategy that they have committed to quite a bit. And it's a long process because, really, if you want to do that well, you have to start way before people are in medical school. We need to start pre-K and kindergarten and start there to really do that effectively. And so they're trying to figure out their role as a county hospital in doing that, which is not easy, and some would argue is outside of the scope of what kind of a hospital should be doing. But I think the more healthcare systems, the more organizations that are thinking in that way and thinking beyond healthcare to the social factors and the social determinants that we hear so much about is a really important part of that. I also think that that looking at policy, so policy with little p policy, right, within a healthcare system, within a public health organization, whatever it may be, is something that's really important. So to understand kind of, I think there's ways that we don't realize that the policies or the language we've used are not promoting what we think they are. And I know that's something that the Department of Health is doing in Minnesota, and using, there's a lot of places using kind of health equity scorecards right now to kind of help them measure some of that. So those are the two things that I feel like are good places to start.
Way in the back.
I really appreciate your research and the things that you shared today, but I have a question. Is there any research that can help those in the communities with these disparities and inequities to have a voice and to be able to articulate what they're feeling and be able to understand some of the things that you shared today?
Yeah, I think that's a huge part of it. And when I think about kind of those, listening to people's narratives and considering or reconsidering what evidence we decide is real, is a huge part of what you just, what you just mentioned. And, off the top of my head, I don't know. I think right now it's individual people who are doing that work and creating those spaces. And I haven't seen any kind of organizations or systems that are promoting, specifically promoting that. But I know, at least in academia, there's people like Chandra Ford at UCLA and Kamara Jones, who's the current president of the association, or the APHA, the American Public Health Association, who are really committed to that. And I hope it's a movement, and that that's what we're working towards.
Thank you very much for your remarks. I'm Laura Gabay. I had a question about because you're at the forefront of this, has there been any research done on the impact on health outcomes for people who then not only have access to food and so forth, but what you're talking about is a lot about racial justice and social justice. So Carol Gilligan does some work around women from low-income backgrounds who get involved in community service or social justice. And it actually impacts the mental health outcomes on a very measurable basis.
Yeah.
Have you seen this elsewhere in the country? Because we're looking at this. I work for the Colorado Cross Disability Coalition, and we work with many people who have very fragile health, and yet when they get involved as social advocates or social justice advocates, we think that it's impacting not just their mental health, but perhaps their attention to preventive care and so forth.
Yeah, I haven't seen any research on that. It's actually something that's kind of been brewing in the back of my mind around, particularly around birth outcomes in the Black Lives Matter movement. So I will be starting a literature review on that soon, but I don't know of anything off the top of my head. I don't know if anyone in the audience does. I'm looking at Megan, but yeah, thank you.
There is some, I don't know how closely it's related, and it's not necessarily in the disabled community, but a lot of the research going around the Gulf states after Deepwater Horizon, after Katrina, and kind of repeated traumas to the community, have recognized that some communities bounce back quicker than others, right? So they're all subsistence kind of living based on seafood and fishing along the Gulf. And then trying to figure out those determinants that make one community bounce back and the other to define the world as the new normal. And what it seems to be is a sense of belonging, community, and community cohesion that we think translates to resilience. So trying to figure out how to measure those items of belonging and community support is where the research world is kind of trying to focus right now. And there's 3 different academic institutions along the Gulf who are taking the penalty money and trying to figure that out.
And I will add that there's some work around kind of the idea of belonging and racial identity. And And there's sociologists have done some work on that and found that it contributes to resiliency. And so I actually, a couple years ago, I'm part of a research team that looks at the experiences of medical students. And so we've been tracking the same students, just under 5,000 students since 2010, and they're now second-year residents. And my particular interest has been in the experiences of underrepresented minority students in our sample. And one of the things that I've looked pretty closely at is the impact of racial identity. So having a strong self-concept and believing very strongly that around, the endorsing ideas around kind of being what it means to be African American or Black and what that means to them. And we went in with the hypothesis that it would be protective, that having a strong or a positive racial identity would result in kind of more or better well-being, or mental well-being in particular, and found that that wasn't the case, that students who had a very strong self-identity as African American were actually suffering more. And so we started looking at belonging and how they describe how they, include feelings of inclusiveness and belonging within medical school. And it's directly related in those spaces, I think, and we're hoping to do some qualitative work to dig into this a little more, but it seems that in these spaces that are where they are very, very much part of the minority, and both in the racial climate. So other work I've done has looked at the fact that a negative racial climate or diversity climate in these schools, so it's 50 medical schools across the US, so a negative racial climate is creating poor well-being for everyone, for the underrepresented minority students, but for everyone. And so we're hoping to do some qualitative work to kind of dig into that more and understand why racial identity isn't protective, and if it's related to this issue of belonging and inclusiveness.
So hi, thank you so much for being here. I appreciate your words and your comments. I too am one of the only, not one of, but the only faculty of color within my department. And so I get the isolation and the degree of invisibility.
Yeah.
But the question that I have for you is that I feel like it's a statement and a question all in one, because I think it's a double-edged thing.
Sure.
So there's this push for the academy to diversify.
Yep.
And then when we show up, we're not really welcomed or
Yeah.
received, because there's
Yeah.
this degree of perceived incompetence, right? So I'm constantly trying to prove that my research and my presence is just as valuable as my white
Yeah.
colleagues. Yet when we show up, it sort of lets people off the hook. So my
Yeah.
question to you is, how do you do both ends? How do you color up the workforce, but yet have everyone still know that this is a collective responsibility, that just because I show up doesn't mean that no one else now is responsible
Yeah.
for creating, a diverse environment that fosters inclusion?
Yeah, I think that's a huge, huge issue, and thank you for raising it. I do not have the answers to that. I think it's something that, in my department, I would say first, we need allies, and creating kind of I've been fortunate enough to create a strong group of allies and people who aren't going to let these issues drop and let people off the hook and saying they check the box because we have two faculty of color or whatever it may be. So I think that's an important, and these allies can't be other people of color, right? They have to be white allies or people who are identify with the majority in some way. I think that's an important part of it. I would love to hear if anyone else has any thoughts, any strategies on that, because I think it's, retention is a huge piece of it. So if you don't feel like, they got you there, but then if you don't feel like you are welcome or included in some way, then, there's no incentive to stay.
I don't have a question. I wanted to kind of bear testimony and echo some of what you were saying, Dr. Hardeman. And I think these words are as much for me right now as they are for anyone else. Mm-hmm. But clearly it is very easy to lose hope right now, to lose heart. And you alluded to that. Ta-Nehisi Coates, he's a writer for The Atlantic, and he wrote Between the World and Me. which is a masterpiece on the experience of being black in America. Many of you, I'm sure, are familiar with this. But I listened to him speak once, and he stated that the only charge he hears, or the only critique he has against his work, is not a refutation of any of the facts, because those are irrefutable. What he hears is, well, that doesn't feel very good, or that's uncomfortable,
Right.
or where's the hope in that? And I heard him give a response, and it stayed with me. And he said that if you were born in the early to mid 1700s, black in the South, you could look back 100+ years into the life of your parents, the lives of your grandparents, and you would see nothing but slavery and bondage. And you could look forward 100+ years into the lives of your children and your grandchildren and see nothing but slavery and bondage. Where's the hope in that?
Yeah.
And I think that hope is crucial, and it can serve as a catalyst for our work, but our work is bigger than hope, or even the desired outcomes that hope is attached to, right? Those outcomes are often beyond our control. Ultimately, we do this work because it is right,
Yeah.
and because we must, to lay the foundation for those who will inevitably come after us, to continue our struggle at a higher elevation, and to serve and honor the legacy of those who came before us 50 years ago, 100 years ago, 200-300 years ago, many of whom never lived to see the world that they were trying to construct and create, the world that we live in today. We have a long way to go, but we have come very, very far. And there's always been tyranny and oppression, but there have always been liberators. And here we are.
And here we are. Thank you.
I'm going to take this pause. Oh,
I just have
Go
a
ahead.
quick question. Sorry, I couldn't see you back there. So I work for an organization that has an equity team, and I feel really thankful that we can have those conversations. But in light of recent events and the news we got yesterday, I found that I'm pretty tired being like one of two people of color in the room, having the conversation of equity. So I'm wondering, like, what are some things that you do for sustainability, and how do you separate that, I don't know, in your personal life? Because I'm finding some of the struggles that I'm having are in my personal life as well with family members. So what are some things that you do outside of work and just on your own to kind of sustain that work? Thanks.
So I think that's a really good question for the whole audience, right? I mean, I am certainly not the expert on that, because it's a struggle, right? It's a constant back and forth, and I personally have trouble separating kind of the personal, the family life, and the work conversations, because it's all intertwined, and you can't. And part of me feels like you can't really separate it. But I would love to know if there's anyone that has any kind of insight on that, who's sitting in this room. And it looks like there is.
I'll offer this. Hi, my name is Carol. I'm from Global Minded, and I have a husband who works for a technology company, and as you know, many of the technology companies have 2% minority in women, and one of their employees is this fabulous gentleman who's originally from Africa and does a great job. And so my husband was on this leadership acceptance committee and rated him, kind of off the charts for the fact that English is not his first language, he does a great job at work, all these reasons. But his boss's boss did not recommend him for this leadership class, so he did not have that buy-in. So my husband went to bat for this individual and got him into the leadership class. And part of what I think we need to put on the table here today is that we need people who are some of the Caucasian males, like my husband, who stand up and fight for and open the door for people of color. I think really being able to see that in a broad way. The second thing is, we were talking about this earlier, we have people on our board like Patty Lopez from Intel, and she doesn't have a lot of other Latinas up at Intel and Fort Collins. So she has to build her network of support from a variety of other people, women and other folks that support her through National Council of Women in Technology and through other networks. So I think where, in my case, in my career, I was the first female assistant vice president. We have to build these coalitions of support from places sometimes other than where we're working. So those are my two takeaways is, one, let's recruit some of the men who are willing to stand up to the people in power and fight for and open doors for diverse and LGBTQ and all kinds of other people who deserve access. And then let's ourselves realize that we can't always look to our place of work to be the place that inspires us and promotes us, but we have a number of amazing people in the communities around us, and we can create those people and be the amazing people of strength to be breaking trail where we need to be going and doing that.
I'm Elise Montez Griego. I work with the Orton Family Foundation, and I love your question because I think we're all facing that in different networks that I belong in as well. And there's been a real conversation around self-care because we can't always have our equity warrior hat on. There are times that we need to go home and be a peace warrior and a take care of myself warrior. And some people have talked about whether you meditate or you just read a book. Like, make sure you take time out to recharge, because it is hard work, and we do go and hit our head against a brick wall every day. So.
Dr. Hardeman, I had a question about advice about naming it and using the word racism. So there are a number of us in the room that have been here for every Health Equity Learning Series event. And I love one of the comments that came out of our first convening of all the HELS, HELS, the Learning Series, unfortunate acronym, the Learning Series grantees. And to paraphrase it was, okay, we get it, it's racism. How do we talk about that? And what they were expressing is that in their communities, the Eastern Plains, the Western Slope, as we dribble farther out from the metro area and we leave the, I would say, relative safety and comfort of audiences like this, there is a real fear and worry and a shutdown that happens with the word racism. And so I hear often, how do we talk about it? How do we bring that up? How do we broach the world? And then I will tell you, I'm willing to be wrong, but I think Colorado is a little farther behind even Minnesota.
Yeah, I mean, I think that's like the $1 million question, right? Is how do we have these conversations and how do we talk about this? One of the things I try and start with a lot, depending